Good afternoon, everybody. Obviously, some of these slides are written for folks who are not necessarily in medicine. We've had a lot of people who do not know what a cholecystectomy is and can barely say what it is, can barely pronounce it. So we tell them, oh, it's about gallbladders, and they all say, oh, okay. So when you start talking to legislators and others, it's amazing how few people know what a cholecystectomy is. These days, it's almost always performed laparoscopically. Most of them are. Most of the open procedures are being done now because of people with abnormal abdomens or abnormal presentations. I think the days of people struggling to do the laparoscopic approach and doing a lot of conversions is more or less over, looking at the data that we had on at least the Medicaid and the Blue Cross data when we prepared these episodes. Nowadays, instead of being in the hospital for a week, people go home the same day as surgery. There are no complications. So we want to reward people who have good outcomes, reduce complications, readmissions, avoid avoidable hospital days. We, in the beginning, talked about possibly doing something with the preoperative period, but it became very complicated because it turns out that most of the surgeons are getting these patients after somebody else has done some sort of workup, be it a primary care doctor for upper abdominal pain symptoms or an ER for somebody coming in with acute pain. So we realized that in terms of fairness to the PAP, as we've had in these episodes, it really has to start when the patient is admitted and under the care of the PAP. One of the things that did pop out in our data was that a lot of these patients, many more than I would have anticipated, were all getting CT scans prior to their procedure. And I'm sure most of you would agree that most gallbladders can be diagnosed and evaluated using ultrasound, which aside from being less expensive is also less risky in terms of radiation exposure. So we in the beginning thought, well, part of the total cost of care management would be part of the CT scanning approach, but we realized that most of these CT scans are probably not being ordered by the surgeons, but being ordered by somebody on a care team. But we thought it would be a fair game, and we talked about it with some of the surgeons, to have as a quality indicator to try to get our surgical teams more engaged with their local providers to reduce CT scanning for people who present with likely gallbladders. Right now, the variation on CT scanning across the state preoperatively ranges from like 20 to 80%, depending on the location, the hospital, etc. So there's probably some practice variation that can be addressed. Next slide. So as I mentioned, patients these days can present non-acutely to a primary care office, have intermittent abdominal pain. Other times they present to the emergency room, and then a workup ensues, and it determines that there is symptomatic gallstones. The people who get admitted for things like pancreatitis or cholangitis, those folks are not included in this episode. They are specifically excluded because that is a complicated presentation. We are more interested in the elective or semi-urgent cholecystectomy. People who come in with a hot gallbladder who without infection, who these days most surgeons would operate on fairly rapidly and not go into the old-fashioned cooling off period. And then, of course, there would be the recovery period and then an observation for complications or follow-up visits as needed if the patient does not respond quickly and completely. Next slide. We designed this episode with several community-based physicians as well as a physician from UAMS. We had several visits with them, went over our data and available literature to view this. We looked at the track record of laparoscopic and open procedures, and we basically excluded open procedures from this episode because most of the time these days it represents a complicated patient and not a failed laparoscopic attempt. Or it would be a laparoscopic attempt that tried well, but conditions precluded it. Probably often in men these days. I guess women get their gallbladders taken out before men, who kind of sit on them for a while, end up with scarred anatomy, and makes life difficult for folks. So the time frame again is the time of the surgery, related services, complications 90 days afterwards, post-procedure admissions within 30 days as defined by the Medicare readmission program, better known as BPCI, Bundled Payments for Care Improvement. We've excluded select comorbid conditions, people who have all sorts of significant comorbidities, a pregnancy at the time of the problem, people who've been in the ICU, people with active cirrhosis, acute pancreatitis, cholangitis. We're going to be looking into about pediatric cases. We got that raised recently, and we really did not envision this to be including 10-year-olds, which might have its own set of issues and confusions. So we'll be looking into the appropriateness of kids in this episode. People who've had a death in the hospital will throw out. Very catastrophic changes to extend the deviations out. Those episodes disappear. People who have dual coverage, etc. I believe, one other, double check before we go further, Medicaid is doing this episode, as is, I think, Blue Cross and Qualitrust. So all three payers in the APII are adopting the episode. But today we're talking mostly about the Medicaid experience. The next slide. Episode cost is adjusted based on the comorbidities. We do risk assessments, so your coding of comorbidities is important because it does adjust the cost, the expected cost of the episode. We do not include the ER procedures. We give you, I think, a half-day grace on the inpatient stay so that you have time to get to know the patient and schedule the procedure, and then expedite discharge and care. We have to have at least 5 cholecystectomies per year per payer to be included in the episode for that payer. We have some quality metrics for reporting. That'll be your conversion rate, the number initiated by open. Some major complications will be listed, such as bleeding, bowel injury, perforations, bile duct injury, etc. And the metric that we'll be requiring for gain sharing payment is the percentage of cases that get a CT scan. And before you get too excited, we're going to set that at the state average, and that's currently about 44%. So in order to qualify for gain sharing, we're asking that your episodes have fewer than 44% of your gallbladders have a CT scan in the 30 days prior to the gallbladder procedure. And again, it's an effort to try to get everyone to talk to their ER docs and their primary care docs about the best way to work up right upper quadrant pain, to start with the ultrasound, not necessarily go straight to a CT scan. And that's, again, for patient safety as well as for costs. And clearly the PAP here would be the surgeon, because they're mostly in control of what happens in the OR and post-operatively. Next slide. And again, we're restating what I've just said. The trigger is the procedure itself, and the trigger would be any appropriate primary or secondary diagnoses. Obviously, those diagnoses that complicate a gallbladder would be excluded. So again, the pancreatitis, the cholangitis. Pre-procedure costs are excluded unless it's after the admission and under the care of the surgeon. Post-procedure windows, we said, related services related to the gallbladder within the 90 days of the procedure, and any all-cause readmissions as defined by the BPCI. Next slide. The services that are included in the episode: lab tests, professional claims, inpatient claims, medications that are related to the recovery, and again, readmissions. Next slide. Again, variations in what we've talked about before, some of the key exclusions, severe comorbidities, pregnancy, ICU stay, etc. We have gone over these in the presentation this afternoon. Next slide. More exclusions, leaving the hospital against advice, death. We're going to look at some of the younger age categories to make sure that they are appropriate. Older than 64 is excluded because that's a Medicare episode then, and if Medicare joins in, they might add the episode. Dual coverage, i.e. people who have multiple insurance coverages, and Medicaid is not the primary coverage. And then people whose enrollment in the program is either unclear or inconsistent at the time of the episode. Next slide, quality metrics. Again, we have the reporting only, which would be the complications, which we pick up on claims. The conversion rate, which again, I think we'd be able to pick up on some claims. And again, as coded, people starting as opens, and we'll be tracking also through claims the CT scanning.